Good morning, I'm Robbin Cohen from the University of Southern California Keck School of Medicine, and this is an STS roundtable on pain management and cardiothoracic surgery. I'm surrounded by a panel of experts, and I'm going to ask them to introduce themselves.
Hi, I'm Linda Martin. I'm a thoracic surgeon at the University of Virginia.
Hello, I'm Steve Yang. I'm a general thoracic surgeon at the Johns Hopkins School of Medicine.
I'm Steve Lahey. I'm the Chief of Cardiac and Thoracic Surgery at the University of Connecticut and the Vice Chairman of Surgery.
I'm Dan Engelman. I'm a cardiac surgeon and I practice critical care at Bay State Medical Center in Springfield, Massachusetts.
So let's just start our discussion. I don't think that you can have a discussion about pain management in surgery without focusing on opioids. The current opioid epidemic in the United States has caused all physicians to reevaluate their prescription writing habits when it comes to narcotics. When it comes to cardiac and thoracic surgery, many of us have been alarmed by not only the side effects of opioids, but recent reports that suggest prolonged use in our patients. So let's just start by acknowledging the problem. Steve, is there really a cardiothoracic surgical opioid issue in the United States?
Well, you know, I think, Robin, that all of us intuitively know there is. We've all read the newspapers and everything, but it was actually, we had very stark numbers from the CDC, and they had noticed that opioid deaths, opioid-related deaths went from 42,000 in 2016 to almost 49,000 in the following year. I mean, so this got the attention of many, many people, and there's a lot of issues that came out of that from Congress.
So how do you recognize a patient who has had an operation and has a opioid problem?
Well, I think there's a couple ways of doing it. One is preoperatively, you can sometimes predict that they're going to have an issue if they're taking a lot beforehand. There are some data to show that younger patients may be having a tendency to be on opioids longer. Certainly post-op, if they keep calling for refills. You know, our practice is that they have to call our office as opposed to kicking it down the road to the primary cares, that we control the refills, the numbers. We don't allow the residents or the advanced practice folks to do that. So we do keep a pretty good control. Getting back to the question earlier, is there a problem? Probably not, don't really see it in our patient population as much, but I think, you know, we just did a survey of the STS membership, not so much of the cardiac patients, but maybe a little bit more on the thoracic side. The survey also did show that about 53% of the cardiothoracic surgeons think that there's an opioid problem. We didn't specifically say there was a crisis, but they do recognize there is a problem amongst our patients.
So what do you do when it's brought to your attention that one of your patients is still requiring opioids longer and out of proportion to what you would expect?
So getting back to your first question, I actually do think there's a major problem. I would actually almost suggest that the continued use of opioids following cardiac surgery beyond a week is a complication which results in a majority of patients potentially becoming addicted to opioids, and that up to 6% of our post-op patients actually do become addicted to opioids. And it can be predicted by those exact patients that you're describing that are still taking opioids. You have a 10% risk of becoming addicted to opioids if you're on them 5 days after discharge, a 20% risk if you're on them 10 days after, and it continues on exponentially. So what do you do? It's difficult. I think it starts preoperatively. I think we have to back all this up to the preoperative evaluation, figuring out who is opioid naive and who's actually taking opioids. Change their expectations about their utilization of opioids postoperatively. And another thing we need to do, beyond multimodal analgesia, which we can discuss as a group, is I think that anybody who's not taking opioids in the 48 hours prior to discharge should not be discharged with opioids. And it turns out a third of patients actually are. No opioids for 48 hours prior to discharge. Here's your script for opioids. And that does not help anybody.
So we've got to be consistent. So Linda, forgive me for being a little too surgical about this, but it seems to me that we have a couple of options. Number one is do something surgically in order to not cause as much pain. And number two, come up with strategies that are better to control people's pain. So what as a thoracic surgeon are you doing, number one, to decrease the amount of pain that you're causing surgically, and then number two, what solutions have you come up with to treat patients with, say, non-opioid medications?
So I'll start by saying we should acknowledge the fact that as thoracic surgeons, we are offenders in causing pain. If you go on Google and you type most painful incision, thoracotomy is the answer, and you can test it if you'd like. But if you look at patients who go in for elective surgery and are opioid naive when they show up at the hospital, but then are still filling opioid prescriptions 6 months later, the number one offender is thoracotomy, but surprisingly the number two offender is VAT, or minimally invasive surgery. So there's this idea that minimally invasive is so much superior to open in preventing pain, but it's a pretty close second in terms of causing pain. So I think just recognizing that and acknowledging it, being ready to address it so that you don't just say, oh, it's a VATS patient, they're not going to have an issue. Well, actually, a lot of them do. So we need to be aware of that problem, and whether that's talking to patients, setting their expectations, that's one thing. I think another strategy that's tremendously helpful is to take a look at how you're managing the patient's pain to begin with and revisit your protocol. And that's something that we did at University of Virginia. We completely changed the way we managed our patients every step of the way, from before, during, and after surgery, and it made a huge difference in our opioid usage.
Okay, so I'm waiting for you to say the magic word, which I think is liposomal bupivacaine. That seems to be
Yes.
you know, something new that's been added to our armamentarium that really seems to be
Yes.
working. Tell us about that.
Well, so I feel that is probably the most impactful intervention that we've taken, but it isn't necessarily enough on its own. It's part of a multimodal, multidisciplinary strategy in our enhanced recovery program, which includes using nonsteroidal anti-inflammatories, gabapentin, we use subarachnoid morphine injections in the spine, so some other things as well, but I think the biggest revolutionary change has been the use of liposomal bupivacaine rib blocks. And I've personally found that that's been a much more reliable way to manage pain than epidurals. I know epidurals are supposedly effective 90+% of the time. I think in practice it's a lot less often than that. And it converts it to a surgeon-controlled analgesic instead of somebody else's doing it. So I think that's really a practice-changing intervention, and there are some things you have to do to make it work effectively and reliably.
So is it surgical? Is it surgeon-controlled in your institution, or is that something that an anesthesiologist should be doing? I mean, those are really the pain specialists that we work with, right?
I think you hit the nail on the head. It's a multidisciplinary process. I think you need a team that's absolutely dedicated to decreasing the opioid utilization at your institution, and every step of the way the nurses need to take a part. The anesthesiologist clearly needs to help, and the surgeons on rounds, and your intensivists, and the entire advanced practitioner team that takes care of your patients every single day has to be thinking, what multimodal alternatives do I have to opioids on this particular patient? And there's a large armamentarium of medications now being used across the country that need to sort of be collated, and we need to look for best practice, and we need to standardize it.
So we've gone from a surgeon-controlled entity to something that requires a multidisciplinary team and teamwork. How do you measure whether or not it's working?
Well, just to go back to Linda's point, now maybe some of the richer institutions can use this liposomal bupivacaine, but some other institutions are not allowed to get them in. So it does go back, I think, to the preoperative phase, where we do need, as surgeons, to do a better job with education. I think in the past we didn't focus too much on it, but you know, we used to say, well, the VATS incisions aren't that painful, but they can be very painful, and we do see people who have chronic pain for it. So how do you manage it, and how do you figure it out long term? They are going to need more medications. Well, you actually have to see how much they're using every day. So we do try to move from parenteral to, for those of us who don't use the bupivacaine, we just still use epidurals. We try to move to oral agents, non-opioids, as quickly as we can. You know, the issue with trying to make sure that they're off of opioids before they go home, so we'll cut into the length of stay, and that's, you know, it's a double-sided sword. So, so we do measure how much opioids they do get in the hospital, and everyone's going to be different, you know, based upon age, body surface area, type of operation, and length of operation. And so we do regulate how much we give when they go home. So not everybody gets the same amount of opioids when they leave here. We actually base it upon how much they take in-house, and then we multiply that by a factor of 2 or 3 and then send them home. Mm-hmm. And we also have follow-up too.
So let me just stick a term in here, extended recovery after surgery, right?
Enhanced.
Protocol.
Enhanced
Excuse
recovery.
me. Thank you. Advanced recovery.
Enhanced.
Enhanced.
Yes.
Enhanced. So that's one of the ways that we've gotten our hospitals to let us proceed, is basically come in with an established protocol, a little bit of data, and do it, you know, along with our other teams, and it's worked extremely well. So when the Society of Thoracic Surgery is concerned, how are we dealing with this issue on a national and legislative level?
Well, as the chair of the workforce on government relations and health policy, we feel this is a major issue for us, and it is one of our priorities for the upcoming year. We've been very, very active in supporting legislation to address this. I think that one of the first things that happened was in October of 2017, the president declared it a national emergency. Now, it's more than just words. There's a lot of legal ramifications when something like that is declared, because it opens up a lot of resources for the various agencies that will be involved with combating this type of thing. So there's a tremendous number of resources, and each one of the agency heads are directed to use everything they can to reduce the number of deaths from opioid overdose. And then in March of last year, the president opened up a government website, which is the crisisnextdoor.gov, and that invites people who have had loved ones perhaps, or they themselves have overdosed but didn't die, and to share their stories with people. It's been very successful. And then the crowning event was in October of this past year of 2018. It was really a bipartisan, bicameral effort. A bill was passed called Support for Patients and Communities Act. And that really, really puts everything into overdrive as far as expanding services, increased access for people who have addictions and things like that. They can get help. It also, interestingly enough, allows us to inspect shipments from China for illegal fentanyl. That's specific in that bill. Mm-hmm. I don't mean to get very political. It's a statement of fact. That's part of the bill. So there's a number of efforts that are underneath the aegis of that bill that are helping us combat this.
So let me just summarize a little bit. So we recognize the problem. We have surgical technology, pharmacological technology, teamwork, and a legislative effort, all aimed at going after this problem in the future. And so when a patient comes to us and says, I don't want to be on opioids, what are you going to do to control my pain? The answer is?
My answer is that controlling their pain is incredibly important to their recovery, and it's a priority. And our goal is to do that in the safest way possible. And so if that means using a sparing amount of opioids, that's okay, and we will make every effort to prevent them from becoming addicted. But we're going to try to shift gears and use other modalities that are less likely to cause addiction.
Add to that.
Well, specifically, like preoperatively, in the area, just right before surgery, an hour or so before surgery, they do get a number of oral medications. So the NSAIDs, the non-opioids, IV Tylenol, IV acetaminophen. And we've seen, and through Linda's work with all of the preoperative medication, that does decrease the need for opioids and other medications post-op. So we are attacking it in the clinic, right before surgery, right before the incision's made, right afterwards. And these days we are trying to get all the other things that we can control, chest tubes out faster, they're walking quicker, getting their oral intakes in.
Very good. So this has been an STS roundtable on pain management and cardiothoracic surgery. Thank you very much.